My task is to talk about exercise recommendations in athletes, both with hypertension or those with ischemic heart disease. And I try to do this in 20 minutes. This is an important topic, and this topic will be increasingly important, as Dr. Megani told us earlier today, because we have more and more athletes out there, master athletes, recreational athletes, mass gathering events, and the athletes are getting older and they are less fit, as shown by this study by Ågård and co-workers, saying that in all finishing quartiles in the cross-country 30K race in Stockholm, all the finishing times were worse than 25 years ago or 15 years earlier. So actually, we have more athletes, older athletes, and probably they have more risk factors, and probably they have more hypertension or ischemic heart disease. First, hypertension. How common is it in athletes? Well, if you look in the literature, it's very varying. One study showed 90% of football players had increased blood pressure, and another article said that 7% in soccer players in Europe had hypertension. So luckily there was a recent meta-analysis published in the British Journal of Sports Medicine saying that, okay, this is highly different in different studies, and this is due to poor methodology. And also there could be small studies, so the difference in prevalence differed between 0 and 45%. So we really don't know how prevalent hypertension in athletes is. But of course, there's no evidence for a lower blood pressure in athletes. And it's a more common problem in older athletes, as shown here by a study in Bern, looking at athletes around 40, 42 years old, master athletes, endurance athletes, and 33% of those were found to have masked hypertension when they did long blood pressure measurements. And there was a twofold increase for the hypertension diagnosis if the office blood pressure was in the gray zone, that's above 120/80. So it's more common in our middle master athletes population, of course. So how do we manage isolated blood pressure when we found it? Of course, the diagnosis of hypertension is a blood pressure equals to or over 140/90, and you have to do it repeatedly for the diagnosis. You have to consider if the circumstances. I think it's not very unusual at all to have a little increase in blood pressure when you do the screening in athletes, because they're excited, maybe they do some further testing and so on. And so what you should do is you should repeat the measurements, you should ensure that it is proper resting position, and that you have the standard and standardized equipment, standard manometry, and if it's a case of white coat hypertension and so on. So if it's borderline blood pressure, you should consider ambulatory blood pressure measurements. And then if you are sure of the diagnosis, you should exclude secondary hypertension. And this is something we sometimes miss, especially in young athletes. It's more than 5% that have secondary hypertension, or more young people, I would say. You had to palpate the femoral pulses, auscultate renal arteries, look at kidney function, electrolytes, consider hormonal factors, and also the medication, and possibly both doping and recreational drugs. For instance, anabolic steroids has been associated with high blood pressure and could be related, if you look at the literature, these are some papers here, could be related to the sodium retention effect of the steroids. Another thing we mustn't forget is if there is the discrepancy of blood pressure in arms and legs. And this was recently found in some young people in Sweden where the old tradition of the doctor looking at the femoral pulses and doing it has been a little bit forgotten, and people rely on more techniques nowadays. So please consider the discrepancy of blood pressure in arms and legs, and if there is a over 20 millimeters difference and higher in the arms, you should rule out coarctation, of course. So and then we have the confirmed hypertension, how do we manage the athlete with hypertension? And what we have to rely on is the ESC recommendations from 2005. And first of all, we should risk stratify. And this risk stratification in the athletes or anybody with high blood pressure is first look at the severity of blood pressure, which was the sole thing you did before. You only looked at the different levels of blood pressure. But nowadays we have to look at also, number two, the other risk factors present and the total risk profile of the individual. And also, number three, look at any target organ damage, which is especially important for the athletes, I would say. Consider the heart, kidneys, and eyes. And then you have the total risk of the athlete. And to rule out target organ damage, you have to look at the eyes. You do kidney tests and also cardiac ablation. And we have most readily both the ECG and the echo available. So for treatment in hypertension, those with could be listed into low risk, moderate risk, and high added risk. And if you have low to moderate added risk, that's a blood pressure below 160 over 100, and have just one or no, 0, 1, or 2 risk factors, then you should have lifestyle advice, regular physical activity, and so on, and medications if these measures fall. And if you're a high to very high risk, you should be treated promptly with anti-hypertensive medications. And of course, athletes and medications and anti-hypertensive, you have to consider two things. First of all, if it's on the doping list, which could be the case of beta blockers, there's been several cases of athletes with hypertension competing at high level, and if they're allowed to do that, if they have beta blockers, especially in some sports, not all sports, especially shooting and sports like that. Diuretics could be also on the doping list, and so the first line treatment today is different vasodilators. That could be ARBs or ACE inhibitors or calcium channel blockers. This is the first line treatment for the normal athlete, and also you have to consider the effects of the VO2 max, right? So not only doping, but also the effects on the VO2 max of the individual. But we have to consider also, just to show you that regular physical activity lowers blood pressure in our patients. And this is coming from the latest chapter in the FIS book, showing that if you do meta-analysis on individuals with hypertension, because most meta-analysis you will find out there is done on people with normal tension and hypertension, and of course the effect in normal tensives is less. If you look at just the hypertensives, you will have a blood pressuring effect of 12 over 5 millimeters for aerobic medium to high intensity training. But for competitive sports, we have to look at the levels and the risk factor profile. And if you have a well-controlled blood pressure and no added risk factors and no target organ damage, there is no contraindications. And this is the normal picture. But if you have a very high blood pressure, over 200 over 115, you should first treat the blood pressure, of course, and then sports is contraindicated until you get the blood pressure down. And then again, you have to really consider the effect of target organ damage and other risk factors. So this is the EC recommendations today for competitive sports eligibility in hypertension. So let's move over to ischemic heart disease. And this could also possibly be silent, right? And maybe this Norwegian skier isn't the normal athlete, but some of these guys go up until 90 in competitive cross-country skiing. So what exercise recommendations do we give athletes with ischemic heart disease? First of all, do they exist? Do the athletes have coronary artery disease? And of course, you listen to Dr. Magani showing us that they do have coronary calcium scores and plaques. So look at these 30K race again in Stockholm. There was 70% males, mean age 62, and they looked at these specifically, looking at the ones selected by high-NT-proBNP. 15 of those had a very high value for NT-proBNP. 4 of those had severe cerebrovascular disease. If you look at the last two guys, male 65, severe coronary disease, triple vessel disease leading to CABG, and the fourth one, 69-year-old, severe coronary disease, silent myocardial infarction, and one of these guys died during follow-up, and the other had a CABG. So these were prepared to run. They were apparently asymptomatic, and they were ready to run the race, which is equivalent to a marathon race, at least. So these guys exist on the starting lineup, and women, I would say. And also younger people could die of coronary disease. This is the case of Owen, the Norwegian swimmer, who was 27 when he died before the London Olympics in the spring. He was the favorite for the gold medal in his particular event, but he died he also had triple vessel disease. So the most common cause of death, even from the age of 25, between 25 and 35, 43% of the deaths in athletes is coming from coronary disease. After 35, it's almost exclusively coronary disease, and before 25, it's very uncommon with coronary disease. So the big thing here is that coronary disease is not all or nothing. This is a nice picture we produced for a review paper last year, and I would say, coming from the left, going from no coronary disease, going to the right, and with the continuous progression of coronary disease, this is a lifelong process. It's not like when you ask patients, they did in Sweden recently, why did you get your cardiac event? And most people answered, because I've been so stressed the last couple of weeks. Nobody, or very few of them, said, that's because I've been overweight, and my blood pressure is high, and I had this, I had this building up for 20 years. People think it's an acute process. It's a long process for many years. So the runners will have different stages of subclinical and clinical disease. And we know also that age makes this process accelerate, and the risk factors will make it accelerate. But it is there. And we also know that physical activity is very good for this process. It will maybe stop this process or slow it down, or even reverse it possibly. But we also know that extreme physical activity, especially as you go to the right on the slide, will have risks. So vigorous activity will have risk in these patients. So this makes it very, very difficult to give advice, right? Because we know that in general population, if you do more activity, that meaning the risk of cardiac events, if you add dose or intensity, the risk of cardiac events will go down, along with lowering risk factors and so on. But what will happen in the other end of the spectrum? As Dr. Ahmed Merghani showed us, that maybe this will, not go down. Maybe it will even out or even go up. So they call it the U-shaped curve. So these kind of events that we had on the 10K recreational race here in Stockholm will possibly happen. We know that vigorous activity will increase, may act as a trigger in underlying coronary disease, increasing the risk from 2 times up to 56 times in different studies. So there is a risk with vigorous activity if you have coronary disease. Interestingly, not only the age and the risk profile of the individuals, because also the risk profile is very important, because looking here at the runners in South Africa, half marathon compared to the ultra marathon. They don't have any marathons in Cape Town. So they do half marathon and ultra marathon. You can see the risk in the ultra marathon was 0. And the event risk. In half marathon, it was 6.7 in 100,000. So actually, it was more dangerous of running the half marathon, it seems. But it's not, of course. It's different populations where the ultra-marathon races have lower risk factors, more races, and better fitness, and so on. So if you do the recreational races, they may have a higher risk. So we have to consider the age, the risk profile of the individual, and also the kind of activity they do. So again, this was a very media-highlighted paper coming from the Copenhagen City Heart Study, saying that if you go from being sedentary to do light jogging or medium intense jogging, the risk of death will go down. But the paper also said that if you're a strenuous jogger and do it very often or very high intensity, the risk may go up. But in fact, the paper can't say anything about that because it was just 2 deaths. It can apparently confirm that the risk goes down if you do more activity than being sedentary, but it doesn't really say if the risk goes up in the end because it's so few cases. You can see there's 2 deaths and the confidence interval goes way above over the 1 line. So to give you an example for the recommendations now, this is a patient I had. He was a 40-year-old master cyclist. He had a myocardial infarction after finishing his race. And he got a PCI for the stent, and he had no symptoms. This was his heart rate curve during the race, by the way. In the end, he wanted to compete again after this myocardial infarction, no symptoms. Do we allow him to do that? What is the advice? So looking at the existing recommendations, coming from 2006 from the ESC, the advice is this. If you have definite ischemic heart disease, no competitive sports. If you have a high risk profile and low probability cardiac events, you can do sports 1A, 2A. That's low to medium static, low dynamic. And if you have a low risk negative exercise test, you can do more extreme sports. And if you have no ischemic heart disease and a low risk profile, you can do any competitive sports. But then again, this was the old way of thinking, either coronary artery disease or not. Nowadays, it's a continuum. And again, these are the sports Elias showed us before. So, and also we should recommend leisure time physical activity. This was also in the old document. We should encourage and prescribe leisure time activity at the safe level, 10 beats below endinal threshold, below the ventilatory threshold, and we should use the rate of perceived exertion. That's the problem I have with all the... Is my time out? Soon. He's coughing, isn't he? Just a few minutes. This is the rate of perceived exertion by Borg. You should use the relative intensity of the individual. That's my problem with all the recommendations. You can do this sport or you cannot do this sport. That's not the right way of looking at it. You should look individually according to the fitness level of the individual, because walking could be low intensity, medium, or high intensity, depending on the patient. So instead of looking too much about different sports, we should look at relative intensity. Because high intensive interval training, that's the new fad, isn't it? And we can even do that in patients with after PCI. The Norwegian study showing that the stenosis and so will decrease. But it has to be supervised, and you have to be individualized a lot. Possibly higher yield by high intensity, but you have to be personalized, and you have to be more careful if you give them advice of doing high intensity activity, including sports. So, just to throw it out there, what advice do we actually give somebody with a previous MI? Stable coronary artery disease, or somebody with plaques on a CT angio? What do we do with this answer regarding physical activity? And even increased coronary artery calcium score. What kind of advice do we give? Do we prescribe them less activity or even more activity? That's very, very, very difficult to decide. This is the first results from the SCAPIS study in Sweden, looking at 30,000 middle-aged people from 50 to 65-year-olds. This is the first 1,000, the pilot. And you can see the presence of lesions in stenosis in the coronary artery disease. Look, going from 50 years to 65, goes up from 30% in women in 50 up to 77% of men over 60. So again, they do have clinical disease to some extent. It's very, very common. Again, comparing a bit with Dr. Megani's data, these were sedentary people without risk factors. But these are the normal population with or without risk factors. So it's very common with some kind of subclinical disease out there. So the updated coronary disease recommendations coming in 2016, what will they say? It's a question mark because we have to collect all these again and revise the recommendations from 2005. For coronary disease, it's definitely going to be more individualized, and eligibility is still primarily going to be based on the presence or absence of exercise-induced myocardial ischemia. Sometimes people think this is old-fashioned, but we're looking at new ways of diagnosing coronary calcium score and CT angio and so on, but those tests doesn't give us any clue of how we should handle the patient. So we must use functional testing to see if there is any ischemia. What is the fitness of the individual? Is there any arrhythmias? Is there any blood pressure lowering? And so on during activity. We should do truly maximal exercise test and Borg over 18, and you should do additional stress testing when found necessary. You should consider the type and volume of sport and the fitness level of the individual and the current risk factor status before you give your advice on the activity level. So the new recommendation is going to be more permissive. I mean, we're going to permit more activity, I think, not saying definitely no to sports activity in the presence of coronary disease, because it's not a yes or no, it's a continuum. So again, I actually end with the same quotation as Dr. Megani, so I think we're on the right track here. Thank you very much.